Assalamu alaikum. Welcome to the Next Gen podcast. Today we're having Dr. Robert Arntfield, a pioneer in the field of ultrasound. Doctor, kindly, can you introduce yourself to the audience?
Of course. Thank you for having me. Robert Arntfield. I'm an ICU physician in London, Ontario, Canada at Western University, where I direct the critical care ultrasound program and I do AI research.
Nice. Thank you so much for being with us today, Doctor.
Pleasure.
The first question I want to ask you about how's your daily lifestyle as critical care consultant?
So, the daily lifestyle of a ICU physician in Canada might be different than in other countries. So I want to offer that first. So we do somewhere between 12 to 16 weeks of clinical service per year. So it's not, so we have a lot of time for academic work. But I could take you through a clinical day, I guess, as a consultant, if that would be of interest to you. Yes?
Yes,
okay,
sure.
Okay. Because, the minority of my time is actually spent on service. Most of my time is spent doing research or teaching, as well as I run a company that is related to AI and ultrasound, which consumes a great amount of my time. So I have a number of different roles.
Okay, so your whole time is not as only critical care consultant. You have another things to.
Yes, and an administrative role is I'm the director of the ICU where I currently work as well. And so I think the thing I would say about an ICU doctor is that, in my life especially, is that it's quite diverse in the sense of not just the patients and the very broad types of illnesses that you manage at various stages, from acute resuscitation to the recovery part of critical illness, to sometimes very stable patients waiting for a ward transfer. But you have enough time, because ICU is usually not all day, every day. You often have a week on and a week off. So you must cultivate outside curiosities and even hobbies to sustain your mind and your practice. And so it's a unique opportunity, and it's also a unique challenge to become an ICU physician for those reasons. In some ways, it's easier to have a job where you just show up to the same job every day with the same type of patient. But the ICU is a different environment, many days with trauma patients sitting next to cardiovascular patients, sitting next to post-surgical patients. So if you are excited by variety and a little bit of chaos, then I think the ICU is a terrific place for you. If you like order and structure, then I think you should become an endocrinologist.
Yeah, but sometimes but sometimes you don't know which type you're gonna like before you try as medical student or intern.
Yeah, no, and I think a lot about this topic, and I talk to students a lot about how to think about their careers. And I think usually it comes down to knowing yourself, which is hard because when you're a medical student, especially I think in Saudi, you enter medical school out of high school. Is that often?
Yeah.
So
you're direct high school to the medical school.
So you're like 18 years old.
Yes.
You don't know anything when you're 18 years old. Yeah. About yourself. You're just learning about yourself. You're just learning what it's like to be independent. And so imagining what specialty you want to practice for the rest of your life is crazy. So the thing that will be stable, though, over those years are things that, let me put that differently. I think the thing to avoid is unnecessarily stressful work. So there's probably a set of jobs that would suit any given medical student or resident, even a subspecialty, based around avoiding the things that stress you out. So the things that stress me out are slow, sort of boring, what I consider to be boring jobs, clinic-based outpatients, with a roster that I'm seeing 60 patients in a day. It's very structured. So if you like structure, it's excellent. If you dislike structure, as I do, that's stressful for me. And so knowing what to avoid is probably the best place to start in thinking about how to form your career. For me, I didn't like the clinic space. I didn't like surgery because it was too, you couldn't do surgery as a medical student to figure out if you liked it or not. So you had to wait in line to maybe get an opportunity as a third or fourth year resident to do the operation. But by then you've already committed, and so it didn't feel accessible. And so resuscitation and ICU felt very accessible to me at an early stage. I liked uncertainty and I liked risk. And so those things, they stress some people out. For me, the absence of risk made me stressed out. And so if you can know those basic principles about yourself, I think you can sort yourself into maybe the right general area. And, you know, and an ICU doctor could also probably be a cardiovascular surgeon maybe, or could also be an emergency doctor or another high acuity specialty. But I don't think that there's good crossover with other types of jobs that have are more stable, like a rheumatologist, for instance.
Yeah.
Do I like order and structure, and do I like thinking about risk? Do I struggle if people die or not? You know, those are basic concepts that I think anybody can ask themselves, and find probably a pretty reliable answer that will be the same answer when you're 18 as it is when you're 68, and that would be the goal. Because the specialty you choose is going to change a lot over the years as you choose the career. And so as long as it's suited to your personality, as much as you can know your personality at a young age, then I think that means that you can grow old with that specialty. Rather than focusing on getting it right, just find it like it's like a life partner. You find there's always trade-offs in having a life partner, or but as long as they match the big areas, then I think you're good.
So your message for them to be curious.
Absolutely.
And try many things.
I love that.
Until you find yourself and a specialty.
Right. And it's not related to, yes, curiosity is the number one quality that keeps someone going. And so I think if you can know yourself first, and most people, we spend most time trying to learn about the body and learning about medicine. And I'm a big fan. For students and residents, I give personality quizzes and tests, because I encourage them to look inwards to be able to figure out where they fit in the outside world. And so if you think of sports, you know, if you're 2 meters 10, maybe you shouldn't be a gymnast, and maybe you should think about playing basketball or something. And so but we don't know, maybe we don't think about, those are very obvious physical qualities. But what about your interpersonal qualities that make you, because we all think we're probably very kind and that we're pretty smart, and those aren't distinguishing characteristics. What is distinguishing is
problem solver.
Yeah, but everyone thinks they're a problem solver. Everyone thinks that they're capable, because you are capable. But I think it's how do you respond to a negative event, a family that's emotionally abusive because they're upset about their loved one being critically ill, which is a normal thing in the ICU. For some people, they will carry that for weeks and it will torture them. For other people, they forget about it as soon as it happens. And so that's a personality trait that you can measure, called neuroticism, which is actually it's like your software as a human being. And so if you understand your own software, you understand what programs you should run. And I think of it that way. It's start with yourself rather than looking at the outside world like it's a menu. It's like, you know, ask yourself what you're hungry for first before you go for the restaurant.
Nice. So we have to discover ourselves before finding the appropriate specialty. So how was the pathway along the medical school and residency and until you become a consultant in your story?
Yeah, in my story, it's a very personal, it's a very lovely question, personal question. So I struggled with medical school in the sense that I think some of the ways I've just been speaking relates to the fact that I was looking at the menu and saying, okay, well, do I like that? Do I like the brain? Do I like the liver? Do I like knees? Do I like diabetes? And saying, no, like, what are the characteristics of the job? What are the type of people who do that job? And that's, you find your answers there. And so I luckily I found some mentors later in medical school whose personalities I really found similar to mine, and they all were clustered around resuscitation and acute care. So emergency medicine and intensive care medicine. And so I ended up going into emergency medicine as my primary specialty, which is how one becomes, ICU is not a direct training program in Canada. It's a subspecialty only. And so I did 5 years of emergency training, and then I did 2 years of critical care training. We'll just make sure it's still good there. Okay. And so, but that was because I recognized people, and I said, hey, you're cool. I like you. You have outside interests. You're not too proud. You're curious. All those qualities you kind of mentioned. And I say, what do you do? And you're like, oh, well, I do ICU. And you're like, huh. And so to me, it was evident that the same personalities were clustered around similar things. And I'd meet someone else and they'd be rude and grumpy. And then they'd say they're part of a certain specialty. And you're like, okay, you'd recognize that the phenotype of different specialties, and there's exceptions. But I think the mentorship was so important to me to role model what kind of person and what kind of job I wanted to do.
And then after 5-year emergency, then ICU for 2 years as a fellowship.
Yeah, so 2 years. I was able to overlap it with emergency, so I was able to do 6 years. So I did sort of 7 for the price of 6, as you could say. And then I became very interested in ultrasound, which was becoming popular at the time for emergency, but it was not yet popular in the ICU world. And so then I went to the United States to do an ultrasound fellowship in Mount Sinai Hospital under the direction of a doctor named Brett Nelson, and then an ICU doctor named Paul Mayo, who were very important figures in my life. And ultimately, I had the fortune to sort of build an ultrasound program in Canada at my center that has become, I think it's fair to say, sort of one of the most recognized ultrasound programs for critical care in the world. And we're very proud of that. And that's, again, been one of the other things I would say to people thinking about their careers, and I always tell people, is that being an expert in something, no matter how big or small, is something that will never grow tired for you. Because ultimately you want to believe that you make a little difference somewhere, and whether that's you're a good administrator or you're a good researcher, but something that's just your own. It's like your own little hobby within your work. And for me, obviously, it's ultrasound, but for other people, it might be that they're an expert in acetaminophen toxicity, or they might be an expert in education, just at their center. You don't need to be a world expert, but just something that when people have a problem, they say, you know who you should call? You should call Batul. She's the one you should talk to about whatever problem. And that's always good for, it's distinguishing, and it sustains you on the hard days in a job like critical care that can be stressful, and where you're not necessarily an expert in one thing because you're a bit of a generalist.
Nice. So the story of the initiating the program, ultrasound, what was it? What pushed you to initiate that program?
I was drawn to ultrasound because it struck me that in the ICU at the time, in the 2000s, we had gotten rid of invasive hemodynamic monitoring, like the Swan-Ganz catheter was very popular. Then it died, and then we had no way to identify shock states really very well, and so then ultrasound was around and became popular. And so the beauty of looking inside the body, like you're holding a flashlight, looking inside at the organs and seeing what was dark, you can now see, and figuring out what's wrong with people and their physiology. It was just so exciting. And so I built the program because I like innovation and I like entrepreneurism, and I wanted to build something that was my own that would give this to people. And so I was very excited to be able to have like an academy where people can come and learn this craft. And we grew it together. The students and the residents and the fellows, they teach me new applications and have interesting cases. And we've all grown together over the past 10 years or so that we've had the program. So it's been a huge privilege to have started the program, and now it's kind of taking on its next generation. In some ways, we have doctors who are joining me to help grow the fellowship, and like Dr. Ross Prager, who's quite well known on social media, and Dr. John Mazamaji, who's doing ultrasound research with us. Nice. And so it's becoming a real phenomenon. But the program was the idea that it's like, why do anything? Why host a party? Why have people over for dinner? Like, it's just because you have to. You have to take action. So the program was modeled to me in my fellowship by Dr. Nelson at Mount Sinai, and I thought, hey, we can do that if we can do what they do in the emergency department, but at the ICU level, it was going to be something important. Great. And we've now had a number of Saudi Arabian people who've come as fellowships to spend 6 months or even a year with us learning ultrasound, who are bringing this back to Saudi. And so it's really exciting to see that they're starting to grow it now here internationally. And it's like, how proud does that make me to have had even the smallest part to play in that? It's great.
Actually, it's a big part. That's small.
That's generous.
Thank you. The other question coming to my mind, the AI. Implementing the AI with the ultrasound. What was the story of it? When did you start it?
Yeah, the story of the AI is sort of a sequel to the story I just told you, which is the desire to give the technology of ultrasound to everybody, and realizing that, sure, it's exciting to train people, including the Saudis, like Faisal Katbi and Thamer Alifan and Tariq Al-Ansari and Badr Al-Shari, and there's more coming. But that's like training one person a year, and or a few residents per month we train, and we're not reaching everybody yet. You think of all the doctors who don't yet know how to use this technology, but all the nurses who could be using it, and all the paramedics, and then it's just they're using stethoscopes or nothing. Soldiers on the battlefield, as we're talking about, astronauts, they don't have any technology for diagnostics, and they're not going to come and do a point of care ultrasound rotation with me anytime soon. And so AI is the way to actually skip the decade or two that's going to be needed to train everybody in ultrasound adoption, and we can just deliver it right into the devices. And so I did a computer science degree in my past, and so when about 7 years ago I began learning more about it, and then we started the program, because ultimately my goal is to make my job as an ultrasound educator kind of evaporate, because build an AI that's so successful that it puts me out of work as an educator. That would be success for me. And so it's this ironic kind of loop where I've learned how to teach people ultrasound, but I've learned that it's enjoyable, but it's not efficient enough. And so let's bring machines and technology in to solve the rest of the problem.
Nice. So in the future, what do you think would be the future of AI in the ultrasound?
My hope would be ultrasound is not expensive. It's very cheap compared to everything else. My hope is that ultrasound becomes like a commodity. So it becomes something that you can buy at the store, even if as a layperson. The way the blood pressure cuff went from being something only a cardiologist could use in the 1950s to something that regular doctors could use, to then nurses, to now something that is in every home and every pharmacy. And so eventually I think that is the arc for ultrasound, because people don't want to have to go to the hospital for testing, but we're now reliant on imaging. And so if the most portable and least expensive form of imaging is ultrasound, and maybe something else will come along. But I would love to see then that everybody can access it, and that everybody can access it easily and safely, because the diagnosis and the guidance for gathering the images is automated. And if we can, that's the only way we can give the power of ultrasound to everybody. So a worried parent in the middle of the night with their child doesn't need to go to the hospital. They can go to the medicine cabinet or the drawer and pull out the ultrasound machine, just the same way that people had pulse oximeters in their home during COVID. And they can see if their child has signs of pneumonia, for instance. A pregnant mother, there's a company out of Israel building ultrasound devices for pregnant women, so they can scan themselves at home instead of having to wait an hour or two in the obstetrician's office. It's a very compassionate approach to things, as long as it can be made safe. And it can't be made perfectly safe. It will never be the same as the expert. But the idea of going from nothing at home or nothing other than going to the doctor is we have to have something in between. Like a home COVID test, isn't a PCR, but it's still pretty good. Yes. Or a home pregnancy test, or
it's helping.
Totally, it's something. It's like an Apple Watch isn't a full 12-lead ECG, but if you're suddenly going to AFib, it'll tell you. So I think there's room for that middle ground. So I'd love to see ultrasound become something that we look back on as. Remember when you had to go to Canada to learn ultrasound, and now you can just go to the pharmacy and get it done there? That would be something.
Hopefully that's going to be here, inshallah, someday. The last question, I want your advice for the resident. If I have machine time, let's imagine, and take you back to the residency, what would you do differently, better?
For my own residency? Or what would I do? Can you...
Okay, let's do it both. For your own residency.
You're very good at this, Fatula. You're very good at the podcasting. You should keep this up. For my own residency, I don't know if I do a lot differently. I trained at a smaller center in London, but I traveled a lot for my electives. I went to France and did an ultrasound rotation. I went to South Africa for my trauma rotation. I went to New York for my poison control rotations. So there's a lot of variety that was in there. So I'd encourage people to do international electives or to do national electives the way I did, frankly, because so much of medicine is culture. So there's very few, as I tell people, there's very few right answers in medicine. It's like high potassium is bad, low oxygen levels are bad, low blood pressure is usually bad, but not always. And then otherwise
different from
you go. You go to one hospital, they do things a bit differently, and one doctor 1 week to the next doctor is very different. And so it's mostly art and it's mostly culturally driven. And so the more that you see that, the more it's frees you from the feeling like you don't know enough. And you realize it's like playing music. You realize there's not a right way to play music if you're confident enough and you know that there's some wrong things to do, but the rest is almost artistic. And so I think once you can embrace that, then you're free to be the doctor that you need to be, instead of looking over your shoulder to see if you're doing it right. And I think Peter Brindley was talking in his lecture about the imposter syndrome.
Yeah.
And so to free yourself from that, I think you need to go and, it's like traveling the world, and you understand humanity a bit better and you understand yourself a bit better by traveling. And I think medically you need to travel to different centers and see, if somebody does it so much differently in one hospital to the next, then presumably there's no right answer.
Yeah.
And I can make up my own style, my own practice of medicine. And so as a resident, your goal is to develop your style of practice, not just to learn how to set the PEEP at an exact disease state. It's to learn how to tolerate being wrong, how to be curious, back to your word, and how to, because those skills will grow with you outside of your residency.
Yeah.
You're never done training. You're never done. If you're curious, you're never done. The only reason you graduate residency isn't because you know everything. It's just like a driver's license. It's just you're good enough to drive on your own.
Yeah.
It doesn't mean you're the best driver.
You learn the way.
Yeah, and you've hit a threshold that it's now safe for you to do it, as opposed to the idea that you've mastered it. Residency for critical care could be 15 years long, and you'd still, on your first day, on your 16th year, you'd see a case you've never seen before. Because you could argue, well, you need to learn a bit more, and there's still some cases you haven't seen yet, and there's too many permutations. And so managing your own comfort with uncertainty, comfort with dying, comfort with difficult families, those are the skills you learn during a critical care training program. And then if you have enough to work with, then go out in the world and do it now. And you learn best by doing.
So you encourage the resident to take rotations outside their countries. Try multiple cultures.
Yeah, I think so that way you free yourself from you recognize that the language of medicine is actually a universal one, and it's not just the center you grew up in, right? Yeah.
Nice. This is the good thing back in your residency. The bad things that you remember, that if you are as a consultant now went back, you would fix things or do it in a good way differently.
I think for me, I think I personally I struggled with residency, and many residencies do this. They encourage residents to do research and do research projects.
Yes.
And so I always found that a bit strange, because how do you research and create more knowledge in a specialty that you're only just learning the basics of? It's like asking you to invent a new technique in something before you've learned the basic techniques. And so that's not necessarily, I think that's something that's a bit flawed with a lot of academic residency programs, is they say, you should do research. And you're like, I'm just trying to learn the basics, and you want me to expand the field. And so I think residencies need to do a better job in general of creating very realistic programs for trainees to learn how to engage in like scholarly work without saying you need to do a research project. And I don't know, do you have a research project that you have to do?
It's part of the residency program to graduate. Research has to be.
Yeah, and so I think that needs to be rethought or better explained in a way that makes it more enjoyable for residents, because usually what happens is you get paired with a faculty who has a project and you become a source of labor for them, and it feels like you're kind of just doing their work for them. Is the worst case scenario. Whereas what you really need is mentorship and someone who inspires you to ask questions. And so I would say that in my residency I probably didn't have a good understanding of how to do that, and it took me a long time to figure out. Now I try to allow residents to have very small achievable projects that they can feel good about. It's easy as a resident to engage, and someone tells you, hey, you should help me with this randomized controlled trial, and you're like, okay, I don't have that much time. And so then the project doesn't go very quickly, and all these things happen. It feels like a bit of, and it feels like a little bit of a letdown, instead of, it should be an area where you go to have easy wins and to feel excited about growing the specialty just small bits at a time. And I think that's a better way to encourage scholarly sort of behavior in residents, because you meet a lot of residents who say, "Oh, I hate research," because it feels like doing your taxes or having to do boring administrative work. There's no awe, there's no wonder in the whole process, and that's what we should be giving to residents, instead of the paperwork just saying file for the ethics please and write 10 emails, and it's like, what? Like, shouldn't that's an administrative task? And what we want is to cultivate, again, the brain to discover, again, if we use the musical analogy, instead of managing ticket sales to the concert, like, you should be in the room with a guitar, just doing whatever you want and playing around with it and seeing what it's, if you tune the strings differently, and that kind of playfulness is really what we should be encouraging, because otherwise we turn people off of research, I think, and because it seems like an administrative task with no creativity. And so a few people can see through that. I wasn't one of the people who saw through that, so I'm only coming to this to close this long story in mid-career, where I'm now doing a lot of research in machine learning and AI, because I'm inspired. And I wasn't ever inspired by the research questions before. And so I would wish for residents to have that. I wish I could have had that.
Because you reach, at this level, you reach the threshold already you want to innovate, you want to discover things, fix things that...
that I know I've already bumped up against the limits of what I'm doing with ultrasound, for instance. So how do I break through that limit? That's not an available thing for a resident. So we were the residents who work with us. I bring them in because maybe they want to learn about machine learning, not because I need them to do the ethics approval, but like, hey, come hang out with our team, see how innovation works, learn how the engineers kind of hang out. Like, we go to dinners and do like all day sort of, hackathons, we call them, where you kind of hang out and you build a culture of winning, and they want to be part of it. And it comes back to mentorship, and it comes back to creating and creating that sort of awe. And so those same residents now that started with that, they now are early career and doing amazing things, because I think they've seen it doesn't need to be so boxed in and so linear. Just like what you're doing. You're doing a podcast and you're a resident.
Hopefully.
But it's incredible, right? Like, this is cool. This is so cool.
Yeah, so this is a dream since a long time. Anyway.
Yes, but good for you. And someone role modeled this to you somehow. Maybe it's not in medicine, but maybe someone else.
There's Dr. Peter Brindley, actually. He has a podcast.
Yes, I've been on it. Yeah,
I heard about his podcast.
That's great.
I'm excited to have
He's very good.
another episode with him. Lastly, I want to ask about the things help you to be more resilient in the residency.
Resilient, can you explain, like, just to find it less stressful? Or
less stressful, accepting things go bad.
Yeah, I think I think a lot of this, again, comes back to my initial comments, that when things go badly, what are things that go, if the specialty you're in is generally one that agrees with your personality, then you have much less stress than someone. So if you made me an obstetrician and I had to spend my day around, as opposed to the ICU where, say, 20 to 30% of people die, I would find that way more stressful than working in the ICU, because then the long hours become long hours under pressure that isn't suited to my personality. Whereas long hours in the ICU, where you're having a meaningful family conversation at 5 a.m. and you're solving for, code status and goals of care, and like, that's meaningful. You go home and you're like, wow, what a night, but like, what a night, as opposed to, ugh. And so I do think making good choices early on, figuring out the career selection, and of course the things you can't control, like we talked about walking in here, who your colleagues are, who your co-residents are, those kind of things you can't control, unfortunately, and they can make things a lot worse, or they can make them a lot better. And so there's some things you can control. It starts with specialty selection, mentors, hopefully, and then some wild cards, which are the, who do you have are you working with a grumpy nursing staff that night, or, just things that kind of make it worse. But, and otherwise it's, having outside pursuits. Like, I think fitness is very important, and being active and playing sports, and reminding yourself as a young resident that you're young. You're spending time with grown-up doctors who are, like mid-career or older, and you're in an adult world, but you might be 25 or 20, whatever, like, and remind yourself that you're not surrounded by, death and dying and all or critical illness all the time. Go have a great night out. Go have dinner with your friends. Go play a game of soccer, like whatever it is, and don't feel bad about it. Like act your age outside of the hospital.
Okay, so you're asking the resident to have hobbies, go socialize, try to do good things for themselves.
Of course, and those seem basic, but it is hard if you go home and you're stressed out and you don't like your job, or you're worried that you're not good enough at your job. And so you have to get those first things right. Otherwise, it's going to feel forced for you to be out for dinner if you feel like you chose the wrong specialty. And that happens to everybody. And maybe the last thing I'll say is I've seen residents change specialties and they become the happiest residents I've ever seen because they realize they have control of their life. And it's not easy to do that, and there's shame over it.
You have to be brave, actually.
Super brave, super brave. But if you're thinking about it, do it. Because if it's not normal to have to lie awake and deal with sunk cost bias of saying, well, I did 1 year, so what's another 5? That's the wrong way to think about it. You're young, and you'll learn from the pivot. So anyway, that's a lot for your listeners to take in. So I don't know if there's more you want me to say, but I feel like that's pretty good.
Yeah. Thank you so much. That's more than good. Thank you so much. Thank you for your time.
My pleasure. Thanks for having me.